Okay, now let's talk about the P wave and the isoelectric line. Uh, to start with the P wave, the definition of P wave is the first positive deflection on the ECG. And actually, when you see the P wave, that means this is the atrial depolarization, meaning that when you see the P wave, it means that the atrium is contracting. We remember that the SA node, the sinoatrial node, is found in the right atrium, and it will generate this action potential, the electricity, that will travel from the right atrium to the left atrium, and both of them will contract. The contraction of these two atria will give me a P wave, which is a positive deflection on ECG. Okay, now let's talk about the normal properties of the P wave. The duration of the P wave, so the width of the P wave is less than 120 milliseconds. And I usually don't like to use the milliseconds here. We use the small squares. So we remember that every one small square is equal to 40 milliseconds. So 120 milliseconds is actually 3 small squares. So the duration of P wave should not exceed 3 small squares, okay? It's up to 3 small squares. And the amplitude, the height of it, that represents how much voltage is the P wave, it should be less than 2.5 millimeter or 2.5 small squares, okay? So it should be in the width less than 3 and in the height less than 2.5. This is the normal thing. The best lead to assess P wave is always lead 2. Always go to lead 2 to look for your P wave, and we will see why. And remember, this is very vital information. In normal ECG, the P wave is monophasic in lead 2. What does monophasic mean? Means it is either positive or negative. That means it's monophasic. Okay, it's one phase only, either positive or negative. And normally it should be positive. And normally in VEV1, and I will tell you why now, physiologically speaking, it should be biphasic. Like it's one of the compartments, early compartment of it will be positive, followed by a negative wave. We will see that. Now look here, guys. This is the normal P wave. We start counting from here, from the beginning to the end of it. It should be less than 3 small squares, 1, 2, and less than 3. And the amplitude should be less than 2.5. It's here 2.1 at most. So this is a normal P wave. Just remember from this picture that we have an interval that is including the P wave. So if we start counting from the beginning of the P wave till the beginning of the QRS complex, this interval is called PR interval. And what does PR interval mean? It represents the P wave, which is the atrial depolarization, atrial contraction, and the delay in the AV node. So this PR segment here is the delay at the VA node. If the VA node is delaying more, this segment will be longer, and the PR interval will be, by definition, longer. Okay, just keep this in mind. We will use it today. Now, why I'm showing this picture again, it's really very important to remember that. Do you remember V1? It was looking at the heart directly at the septum, right? It is looking at the septum. The septum is almost here. So V1 is looking at the septum, and the electricity is being generated from the SA node here. And we remember that electricity will travel from the SA node down to the left atrium first, and after that will go to the right atrium. Sorry, from the right atrium, and after that would go to the left atrium. This is the left. Okay, so initial part, look at VA here, the V1, sorry. V1 is the electricity initially will going toward V1. So it will give us a positive deflection. And after that, the electricity will go away from the V1 and goes to the left atrium, meaning that it is going away from the V1, it will be negative deflection. If we remember from first video introduction, we said the electrodes, if the electricity is approaching an electrode, it will give me a positive deflection. And if the electricity is traveling away from the electrode, it will give me a negative deflection. Now, look here. Look, let's talk about lead 2. Lead 2 is here, right? So when we are talking about lead 2 is looking at the heart from here. And the electricity is coming from SA node down to the atrium, and after that to the ventricles. So it's not going away. It's going along with the lead 2. Lead 2, actually, let me precisely do it. So this is AVR here. This is AVF. So lead 2 is coming like this. Okay? So electricity is going everywhere in the heart. So the lead 1 will see it as if it is positive deflection. Okay. Now let's talk about AVR. AVR is looking here, right? It's looking at the heart from the right border. Okay. So the SA node, when it generates electricity, the electricity is always going away from AVR. So the rule says P wave in AVR is always negative because it's traveling away from the AVR. All right, so this just to keep that in mind. All right, now let's talk more in details about what are the components of the P wave. If you can see here, guys, P wave can be divided into 2 phases. Remember, electricity will be generated first in the right atrium. Okay, so the bulk of electricity, the amplitude, the amount of electricity that is generated, it depends on the muscular amount or the muscle amount in the right atrium, right? So the first third that is here represented by this blue triangle, this third of the P wave is coming from, or this half of the P wave is coming from the right atrium, okay? And remember that electricity itself is generated from the SA node that is found in the right atrium, meaning that the amount of electricity, okay, that is generated, that is representing the P wave will be determined by the muscular amount of the right atrium. So if I have a right atrium enlargement, meaning that the muscle of the right atrium is larger because it's enlarged, right? In this way, the amplitude of electricity that is represented by the P wave will be higher because the muscle is larger, okay? So in this case, the P wave will give me a longer amplitude because the electricity amount is larger, okay? Now, let's continue about the normal thing. So we said like the first half of the P wave is coming from the right atrium. How about the second half, coming from right atrium, yes? And the second half is actually coming from the left atrium, okay? So the electricity is traveling from the right atrium to the left atrium. And when it reaches the left atrium, it will give me the second half of the P wave. Now, the left atrium, which is the second atrial to the second atrium to get the electricity, if it is enlarged, meaning that the electricity needs to travel a longer distance. And be careful here, we are not generating a new electricity. It's the same electricity that is being generated from the SA node. But if the left atrium is enlarged, meaning that the electricity needs more time to travel all that distance. So if we have a left atrial enlargement, the duration of the P wave will be longer, okay? So this is really very important. We'll talk about it later. Okay, so just keep that in mind. So again, P wave has 2 components. The first component is coming from the right atrium, and the second, and it's determining the amplitude. And the second component is coming from the left atrium and is determining the duration of the P wave. Okay. My other question is how to know if rhythm is sinus. What does sinus mean when we say sinus rhythm? Sinus rhythm means that the electricity is being generated from the SA node, okay, by itself, only SA node. So if the rhythm is coming from the SA node, it's called sinus. How to know this? This is a huge and easy trick. Always look at lead 2, P wave should be positive. And look at AVR, the P wave should be negative. This is the only rule that you need, okay? So to say sinus rhythm, look at lead 2 and AVR. Lead 2, it should be positive, and then AVR should be negative. That means it is sinus, and we know why from the diagram. Okay. If it is not sinus, meaning that it is negative in lead 2, that's it. If it's negative in lead 2 or positive in AVR, meaning that's not coming from the sinus node. So from where we can get a P wave? We have actually 2 sources. Either from the atrial wall itself, somewhere in from the atrium, maybe from the right atrium, maybe from the left atrium, or the interatrial septum, or maybe sometimes they're coming from the walls, the wall of the inferior vena cava, superior vena cava, pulmonary veins, anywhere. Okay, any focus can generate a P wave. Okay, so this is the first source. The second source is the AV junction, atrioventricular junction. If you remember, guys, there is a fibroelastic cartilage separating atria from ventricles. Okay, at that cartilage, there is a small hole to allow bundle of Hess to get in there, right? Now, at bundle of Hess, at that point that is penetrating the fibroblastic point, we may have a focus of electricity being generated. Okay, how to differentiate? So if the P wave is not sinus, we should localize its site. We look at it's very simple, guys. We look at the PR interval. Now, imagine that. Imagine there is a focus in the right atrium or the left atrium or interatrial septum. And if this focus starts to give me pulses of electricity, okay, these pulses will be arrested at the AV node, okay, and will be delayed before hitting to the ventricle, right? So the PR interval may be normal or maybe prolonged because that represents a delay, okay? So at this point, I know this is an atrial wall focus. But if the new focus is being at the bundle of Hess at the AV junction there at that point, it's already bypassing the AV node, right? So the electricity that generating the P wave will immediately be transmitted to the ventricles. So the PR interval will be very short. Okay, so we look at the PR interval. If it is normal or prolonged, that means the new focus is from the atrial wall itself. But if the PR interval is short, meaning that it is coming from AV junction. Okay, is that clear? It should be very clear, guys. Again, if the P wave is not sinus, if the rhythm is not sinus, what does not sinus mean? Meaning that when I'm looking at lead 2, it is negative and AVR is positive. It's the opposite of the normal thing. We should localize its location. Where is the focus that is giving me this rhythm? Is it either in the atrial wall or at the AV node, at the AV junction? If it is in the atrial wall, meaning that this electricity will be held or will be delayed at the AV node. So the PR interval will be normal or maybe increased. But if the new focus is at the AV junction, meaning that it is already bypassing the AV node, the P wave PR interval would be shorter. And this is so great example, guys, we have to know. Okay, as I told you about this picture, AVR here is looking at the heart from the right side, and the electricity is going at this side like this. So it always will perceive the P wave as negative deflection. Okay, but if I have a focus, let's say here, a focus here, electricity will go everywhere. So the AVR may perceive it as positive or negative or silent, like no P wave, whatever. But it is not sinus. We should know this, guys. Okay. Okay, let's talk more about the diseases that we can have with the P wave. So if I have a right atrial enlargement, meaning that the right atrium is enlarged, you remember, guys, right atrium, if it is enlarged, meaning the muscle itself is largely enlarged, right? More enlarged, meaning that the amount of electricity that is being generated is higher. So the P wave will be taller than normal. Look here, the first half of the P wave is taller than normal, but the duration of it will be unchanged because the duration is determined by how far the electricity should reach the left atrium. Okay, so in case of right atrial enlargement, the P wave will be taller than 2.5 small squares, but the width will remain unchanged. This P wave has a specific name. It's called P pulmonale. P pulmonale. Why we say pulmonale? Because historically speaking, pulmonary hypertension is a classic example that give us right atrial enlargement. Because if you have pulmonary hypertension, the right ventricle is having a hard time pumping blood to the lungs. So it will be enlarged, and this enlargement will be reflected to the right atrium as well. So right atrial enlargement will be seen. So it's called P pulmonale. Now, and if the left atrium is enlarged, if the left atrium is enlarged. Remember that left atrium does not generate electricity normally. So it depends if it's enlarged, meaning that the muscle is increased. So the electricity that is coming from the right atrium needs more time to reach all the muscle of the left atrium, meaning that the duration of the P wave will be increased. So the amplitude will be normal, but the duration will be prolonged. Okay. And this is called P mitral. Why P mitral? Again, guys, if we go back to this picture here, remember we have a mitral valve here separating left atrium from left ventricle. If there is a stenosis, so the left atrium will have hard time pumping blood to the left ventricle, so it will be enlarged. So that's why it's called P mitral. Okay. Now in P mitral, guys, there is this like a very easy feature that you can recognize easily, which is the pivot or this notch here. If you see this pivot, this is by definition the P mitral and indicates left atrial enlargement. Sometimes you will have both left atrial enlargement and right atrial enlargement, and this is seen in cases of severe heart failure. Okay, if you see both of them, you can see that the amplitude is enlarged, prolonged, is taller than normal, and the duration is longer than normal. So you will have a biatrial enlargement. Okay, common P wave abnormalities, we have 4. The first one is the pivot P wave, which is P mitral, and we discussed this. This is seen in left atrial enlargement. We have P pulmonal or peaked P wave, and this is seen in right atrial enlargement. We have P wave inversion. So guys, what is P wave inversion? If we look at lead 2 and it's inverted, like it's negative, meaning that this is not sinus. You have to localize its source. It is either ectopic atrium, like it's coming from a focus, ectopic focus in the atrium, or junctional, and we learned how to differentiate. And the last one is variable P wave morphologies. Like if we can look at the P wave and you find like it has very odd lockings, every time has a different shape, meaning that there is not one foci giving me this P wave. So in this case, it is called multifocal atrial rhythm. And if there is tachycardia, because of this, we called it multifocal atrial tachycardia, MAT. And MAT is seen in cases of severe COPD and hypoxia. Okay, let's see here. Let's take some examples, guys. Okay, this is, as you can see, the duration is prolonged. We can start counting from here to here. 1, 2, 3.5, which is abnormal. And it has this pipette picture. So this is P mitral. And if you can, like, to easily remember that, it makes an M letter, right? So P mitral is very easy to recognize. And that means you have a left atrial enlargement. What about this one? Look for the duration. The duration is normal. 1, 2, and less than 3. Or maybe 3. No, it's less than 3 because we start counting from here to here. Okay, but it's really prolonged. It's really tall. 1, 2, 3, 4. 4 small squares. So this is P pulmonal and seen in right atrial enlargement. Okay, what about this one? Look here, guys. We have an inverted P wave. Inverted P wave. And whenever you find inverted P wave in lead 2, you have to know where is the source. So look here for the PR interval. We start from here to here. By the way, PR interval normally is from 3 to 5 small squares, not shorter than that and not longer than that. 3 to 5 small squares. So here it is only 2 small squares from the beginning of the P wave to the beginning of QRS complex, which is really shortened. So this is called junctional rhythm. Junctional rhythm. Sorry, I'm not good at writing, but this is junctional rhythm. What about this one? Again, this is inverted. So this is abnormal. This is negative. So you need to know what is the source. We can start counting from here to here, which is 1, 2, 3, 4, which is normal PR interval, meaning that this is coming from ectopic atrium. Somewhere in the atrium muscle, a foci is giving me electricity. Okay. What about this one? Look here, guys. If I'm looking here, the P wave has a shape. Here's a different shape, and here's a third shape. This is called multifocal. And to say multifocal, you need at least 3 different shapes. As we can see here, we have 3 different shapes. So this is called multifocal atrial rhythm. And if you have tachycardia, it will be called multifocal atrial tachycardia. Okay. The last thing here in this video, we are talking about the isoelectric line, how to determine isoelectric line. Sometimes it's easy to determine, just like draw this line here. This is the isoelectric line. Very simple, right? But it's not always the case. So the best way to determine the isoelectric line is to look for the T wave. Remember, this is PQRS T wave. PQRS T wave. So this space here between the T of one complex and the P from the following complex. This is the isoelectric line. So I use this line to draw my full line here. Why I'm telling you this? Because sometimes, guys, it's really very hard to determine isoelectric line. And it's really very important because when we want to see the ST depression or elevation, for example, here, what do you think? So we go to the line. We don't start from here, although it's correct for this EKG, but we start from after the T wave. So this is my isoelectric line, and I go through like this. Okay, sorry. Oops. Okay, like this. Okay, so this ST segment is actually not elevated here, although it's sloping. So this may be like an early myocardial infarction. We can see this. Okay, what about this one? Again, this is not the isoelectric line. We start from here. So it's depressed. So this is ST depression, okay? And what about this one here? If you can see, guys, we can't rely on this one. We go with, sorry, we can't rely on this one. We go with between the T and the P wave. And we have this line here drawn like this. So as you can see, the PR is depressed and the ST segment is mildly elevated, okay? If we look at the line like this, they are a little bit, there is elevation and some depression. So there's ST elevation here and PR depression, but the ST elevation is not very prominent. Okay. And now my question for today is, what is your diagnosis? What is the murmur that you can hear when you see this EKG? If the patient has this EKG, okay, what type of murmur you will hear on physical examination? And thank you.